and then the next month after that is you know, toward the end of the month is our trip. So it's gonna be a fun couple months.
That's great. I was born not far south of Boston. I like New England.
Oh wow, very good. This will be, believe it or not, my first trip ever to Boston. Yeah. So
you got to get yourself. If you eat seafood, you got to. If you eat seafood, you got to. I recommend getting a lobster roll at some point, and clam chowder. No one does clam chowder like they do in New England.
I'm looking for it. I'm actually, you know, doing it right. The minute I get off the plane, my buddy's picking me up at the airport. We're going to Fenway Park for the Red Sox versus the Indians on Wednesday, April 17th. So it's going to be a lot of fun.
It's great.
All right. Well, I think we're good. We have great crowd today. Welcome to Roy Benke Grand Rounds lecture series, another Thursday here. So this is Dr. Joe Lizama, Vice Chair of Education. And we have a very, very special speaker today, Dr. Marc Silva. Dr. Marc Silva is a neuropsychologist at the James A. Haley VA and is assistant professor in our Department of Internal Medicine. Marc graduated from the University of Central Florida when they were known as the Golden Knights. Now they're just known as the Knights. And he got his PhD at Marquette University in counseling psychology. Marc then came for a neuropsychology postdoctoral fellowship at the James A. Haley VA and has been on our staff for hard to believe 11 years. Time flies, you know, 13 if we add the postdoc as well. Marc is off to just an incredible start in his career. Recently received the ACRM Brain Injury Joshua Cantor Scholar Award, and also has received the APA Division of Rehab Psychology Rosenthal Early Career Research Award. He has numerous other distinctions that he has received, but one of the things that he has done so brilliantly is taken in clinicians interested in moving on research and moving into a research space. And he has been an incredible mentor for me in the Risa Richardson Grant Center group. And it was a pleasure to get Marc into our Department of Internal Medicine through Risa Richardson's mentorship. And it is a pleasure to have Marc give us his take on obstructive sleep apnea and traumatic brain injury with a very heavy research spin. So I'm going to give it to Marc Silva to take it away. Thank you, Marc.
Thank you so much, Dr. Lizama, for the introduction and for the opportunity to talk about an issue that I care about quite a lot. Well, two issues, traumatic brain injury rehabilitation, which I've been a neuropsychologist in the TBI rehab field for many years, with a more recent interest in sleep and just seeing how those two conditions can interact to potentially hinder or facilitate recovery after a traumatic brain injury. So thank you for giving me the opportunity to talk here, and for Jennifer Newcomb for facilitating this session. I'm going to shut my video off just because I sometimes have bandwidth issues. And you should be seeing my screen with some slides in front of you.
You're good. Perfect.
Great. Unfortunately, I cannot see the chat as I'm giving the talk. If you have questions at any time, feel free to put them in the chat and we can get to the questions at the end of the lecture, or feel free to interrupt me at any point if you have questions. So disclosures, these are my views. They're not the views of the Department of Veterans Affairs or USF. Here are my learning objectives, but in a nutshell, really what I'm hoping to accomplish here is to just hopefully kind of share some information and for people to take away that there's quite a common co-occurrence of sleep apnea and traumatic brain injury. And these independently cause damage to the brain, but there are ways that we can probably intervene in order to help our patients with sleep apnea and TBI be more adherent to their treatment in order for them to really benefit as much as they can from the treatment. these are my key takeaways. If you take away nothing from this talk, really, I just want to share that sleep apnea is associated with a whole host of physical and mental health consequences. Sleep apnea commonly occurs in traumatic brain injury. Treatment adherence is quite poor, although there are behavioral interventions that can help individuals improve their adherence to sleep apnea treatment. And when I say treatment adherence, I'm really talking about PAP therapy, the first line treatment. And we think that these behavioral interventions can be adapted for cognitively impaired persons with TBI. So first, I want to show you this figure, this theoretical model of how sleep can interfere with traumatic brain injury outcomes. I'm going to come back to this figure later, so I'm not going to spend too much time on it now, but I just want to share that we believe more and more that when sleep is disturbed, it can have direct and indirect influences on how people recover from their brain injury. I usually like to start my talks with definitions. I imagine everyone on this call, of course, probably knows what a traumatic brain injury is and probably has treated brain injury patients, but I usually feel like it's a good place to start. So a simple definition, traumatic brain injury is an externally caused disruption in normal brain function. That can be caused by any kind of blow to the head or the head striking up against an object, like a car steering wheel, or in sports. Traumatic brain injury can be caused by rapid acceleration and deceleration, causing the brain to ricochet against the inside of the skull, like thinking about like high velocity vehicle crashes, or for our veterans that are parachuters, jumping out and parachuting and having a really hard landing and hitting their head on the ground. But also by objects penetrating the skull, like a gunshot wound or a projectile. Here is the VA DoD TBI definition, which is basically an expansion of the simple definition. It's traumatically induced. It causes structural injury or physiological disruption to the brain, and it's because of an external force. This is what separates traumatic brain injury from internally caused injuries like stroke or aneurysms that burst or anoxic injuries. Traumatic brain injury is diagnosed by first evidence of some blow to the head or impact to the head, but in addition to that, a clinical sign that brain function has been disrupted. And that can be evaluated in a lot of different ways. It can be evidenced in a lot of different ways. So it can be like a loss or a decreased consciousness of someone who appears stuporous, or maybe goes into a coma after their head has been injured. It can manifest as memory impairment, retrograde or interrograde amnesia. It can manifest as a neurological deficit that can be transient, it can be persistent. Or in the absence of that, any alteration of mental state like confusion or disorientation. And even in the absence of those things, any presence of an intracranial lesion on imaging immediately following the event. Intracranial injuries can be contusions to the brain parenchyma. It can manifest as hemorrhages, epidural hemorrhages, subdural hemorrhages, subarachnoid hemorrhages. These can sometimes expand and push against the brain tissue, causing damage. In some severe cases, this can cause herniation. CT is usually the imaging of choice after an acute brain injury. It's important to share that not all head injuries are brain injuries. The brain itself is protected. It is bathed in floating in cerebral spinal fluid and surrounded by layers and layers of tissue, the meninges, and inside of our skull. So when someone has a blow to the head, it may simply be a head injury, but not necessarily a brain injury without evidence of those clinical signs of physiological disruption to the brain. When someone has a moderate or severe TBI, it's usually pretty obvious on imaging, or the clinical signs are pretty obvious that the brain has been damaged. With a milder brain injury, that can be more difficult to evaluate because often imaging will be clean in the days following the injury, if CT is even conducted, because of clinical guidelines, you don't necessarily order a CT for everyone that comes in with a mild brain injury. But those behavioral manifestations are key to helping to differentiate between a head injury and a brain injury. The incidence of TBI has increased over time. This is data from the CDC, tracking incidence rates from 2006 to 2014. The most recent data suggests that 2.8 million brain injuries occur in the United States on an annual basis, and this rate is increasing over time. The scale of this figure in front of you, it's really hard to tell with the scale being as it is, but there has been a slight uptick in the hospitalizations after brain injury, as well as an uptick in the deaths acutely following a brain injury. So in the United States, about 2.8 million a year. Looking worldwide, the estimates are about 27 million. Brain injuries, particularly if they're moderate or severe, can cause a whole host of cognitive impairments, physical impairments, emotional and behavioral impairments. And the impairments, brain injury, because the location of the brain damage, the location of the contusions, the hemorrhages, uh, they may occur in different areas of the brain. You might have a coup or a counter coup injury. No one brain injury is going to result in the same forms of cognitive impairments, emotional behavioral impairments, and physical impairments, because it's going to be tied to, one, the location of the brain injury, but also the severity of the brain injury. Acutely, even in mild TBI, acutely, you will often see some attentional deficits and maybe some memory deficits in the minutes, the hours following the event. But in most cases of mild traumatic brain injury, those deficits resolve quite quickly. But in more moderate to severe forms of brain injury, the cognitive, physical, and emotional impairments can be lasting. There are estimates that there are about 5.3 million US citizens living with chronic disability due to their traumatic brain injury. This accounts for about 2% of the population. A little bit about the recovery curve after brain injury. So the old way of thinking was that when someone has an acute brain injury, being that mild, moderate, or severe, there is this sudden impact, this sudden presentation of mental impairment that improves rapidly in the hours, the days, the weeks, the months following the event. With once you kind of go a couple years out, the recovery from the brain injury stabilizes. There may be some subtle improvements, but in general, people sort of plateau in their ability to recover from the memory impairments that they experience, the attentional impairments that they experience, the social behavioral impairments that they experience. So it used to believe rapid change, rapid, like marked deficits, rapid recovery, and then a plateau. But more recent data, again from the CDC, shows that is not necessarily the case. There are various trajectories of recovery from moderate and severe TBI when we follow people longitudinally over many, many, many years. So this is data following people up to 5 years after their injury. The figure that you see in front of you is how much they changed on the Glasgow outcome scale. In this group of individuals, this is multi-center data, 39% of them remain unchanged from previously established gains in their functional capacities. But about 26% continue to improve over these many years, whereas a substantial portion, 44%, declined. So they had the brain injury, they made a rapid recovery, they were assessed at 1 year post-injury, they achieved some level of functional improvement. But then between 1 year to 5 year, they actually declined. What might be influencing decline, or what might be influencing the lack of improvement that people might have when we follow people 5 years out after brain injury? This is where me and many of my colleagues think sleep plays an important role. So sleep disorders like obstructive sleep apnea, we believe can directly impact TBI recovery and TBI outcomes directly by disrupting the endogenous neurorestorative processes that happen during sleep, but as well can interrupt TBI recovery and TBI outcomes due to the secondary effects of just poor sleep, resulting in daytime fatigue, resulting in just inability to fully engage in rehab, thus not being able to reap the full benefits of rehab, having a secondary effect on their outcomes. Why would sleep be important? So, over the last 10 years, I think, there's been a lot of more research focus on the glymphatic system. And the glymphatic system is much more active during the sleep period than during the awake period. And during sleep, there is a shrinking of the cells. There's an increase in the CSF, and basically a mechanical flushing of the toxins that accumulate in the brain during the waking hours. This doesn't happen during we're awake, or perhaps it is more appropriate and more accurate to say it doesn't happen to the same degree. How much sleep do we need? I'm just going to pose this to the group that's on the call. How many hours of sleep do you think that adults need per night in order to have like the optimal functioning? And I can't see anything in the chat, so if folks just want to shout out a number.
8 hours.
And we have an answer of 5 in chat.
Yep. 5. Oh, that's low. That's really low. It changes as we age. This is data from the American Academy of Sleep Medicine, who put out a position statement 2 years ago, 3 years ago. The amount of sleep that we require in order to function optimally, it does change as we age. We need more of it when we're young. But for most adults, at least 7 hours per night is felt to be sort of the standard, the minimum number of hours to really benefit from the neurorestorative processes that happen during sleep. Because when we're sleeping, there are physiological things that are happening that are not happening when we're awake, and there are different stages of sleep, and there are things that are happening physiologically in the deepest stages of sleep that are not happening in the lightest stages of sleep. So it's not simply the quantity of sleep that we get a night that matters, but also the quality of sleep. When we have sleep loss or sleep deprivation, we aren't spending the required amount of time in REM sleep, for example, or in stage 3 sleep, which is the deepest stages of sleep. This is data that my colleagues from Mount Sinai in New York, and I collaborated with them on this study that looked at the rates of a variety of different health conditions in individuals with moderate to severe TBI who were demographically matched to the general population. And what we found in this case control study was individuals with moderate or severe TBI were 2.7 times more likely to have some form of chronic sleep disturbance. So I'm going to shift a little bit and now start talking about sleep apnea specifically. Sleep apnea, which I'm sure everyone probably on this call has heard of and probably have treated patients that have the condition. But for review, it is a sleep-related breathing disorder in which the airflow is disrupted despite ongoing efforts to breathe, which separates it from central sleep apnea. These disruptions are caused by, well, the airway basically collapses, obstructing the breathing. These collapses, this obstructed breathing usually lasts about 10 to 30 seconds. It can last up to a minute. And then the brain starts sending signals to the throat muscles to dilate in order to restore breathing. This process is cyclical. Some individuals with sleep apnea, this process of obstructed breathing can occur hundreds of times over the course of the evening, which you can imagine is not good for the brain or the body to be deprived of oxygen. These obstructed breathing has an immediate consequence and impact to the cardiovascular and nervous systems. There is a drop in oxygen levels in the blood. There's an uptick in carbon monoxide in the blood, carbon dioxide. There is an increase in cortical arousal as the brain tries to wake up enough in order to send signals to the throat muscles to dilate. There's an increase in blood pressure and heart rate, catecholamine release. There's basically a sympathetic nervous system activation. The cortical arousals and sometimes full awakenings result in sleep fragmentation as the individual is drawn from deeper levels of sleep to later stages of sleep or full awakening. And there's a lot of evidence to show that obstructive sleep apnea leads to cardiac damage and vascular damage. There are sort of three hypothesized mechanisms of cardiovascular dysfunction and obstructive sleep apnea. One, the intermittent hypoxia sort of driving the issue. Another one, intrathoracic pressure causing mechanical pressure on the heart and the artery walls. And then the arousals that occur, the cortical arousals, activating the sympathetic nervous system, leading to spikes in blood pressure, damaging the arteries. It is pretty well established that the consequences of untreated sleep apnea are vast. These are odds and hazard ratios and relative risk ratios. Untreated sleep apnea results in all kinds of health events like stroke, health conditions like hypertension, heart failure, reduced insulin tolerance. It's linked to depression. It's linked to coronary artery disease. It increases risks of people having occupational accidents and motor vehicle accidents. And sleep apnea, especially when it's more severe, is associated with early mortality. There are a variety of meta-analytic studies that show that individuals with sleep apnea are more at risk for having depression disorders with a pooled prevalence rate of about 35%. About 32% are at risk for anxiety disorders. And they are at higher risk for cognitive dysfunction as well. What you see on the screen in front of you is a meta-analysis from the Archives of Clinical Neuropsychology. Various cognitive domains have been arranged here in descending order. The red box highlights the effect sizes, where the closer you are to 1 shows a stronger effect. In a nutshell, virtually every cognitive domain that was tested in this meta-analysis shows an effect. So it is widely believed that obstructive sleep apnea affects cognitive performance across virtually all domains. I think this slide is out of place, but what I wanted to show here is that there is data to support that people with sleep apnea, compared to healthy controls and compared to primary snorers, people with sleep apnea spend much more time in the lighter stage of sleep, N1, and the less time in the deeper stages of sleep, stage 3, which of course means that people with sleep apnea are spending a lot less time in the stage of sleep that is responsible for the neurorestorative processes in the brain and the parts of sleep that are linked to memory formation, which may explain why there is a link between sleep apnea and cognitive dysfunction. So again, a little bit more about how sleep apnea affects cognition. This is sort of my take on the literature on the topic, and my physician colleagues can probably explain this a lot better than I can. I'm a psychologist, but it appears that there are multiple hypothesized mechanisms of cognitive dysfunction in individuals with sleep apnea, with intermittent hypoxia resulting in chemical changes in the brain that can be neurotoxic, that can result in neuronal death. But also intermittent hypoxia can cause systemic inflammation, which can lead to demyelination, so changes in the white matter of the brain. There's also this inflammatory response, which can suppress amyloid-degrading enzymes in the brain, resulting in a less ability to clear out the amyloid beta production that's occurring, which can result in neurodegeneration. And finally, just poor sleep leading to daytime fatigue and sleepiness, also having an impact on cognitive functioning. So is there any data to support that obstructive sleep apnea results in brain changes? And the answer is yes. So there's been several meta-analyses. This is one of them. 8 studies, 200 sleep apnea patients, almost 200 controls. And what this study found was gray matter reductions in the bilateral parahippocampus, bilateral frontal gyrus, bilateral middle temporal gyrus. Of course, these are areas of the brain that are vulnerable to intermittent hypoxia and vulnerable associated with memory formation and the executive functions of the brain. This separate study found that individuals with sleep apnea compared to healthy controls have altered cerebral blood flow in the frontal and subcortical gray matter structures of the brain. This other study showed that there is abnormal white matter pathology in the brains of individuals with sleep apnea, which this has been associated with less functional connectivity of different brain regions. So in addition to the health impact of sleep apnea, there's also an economic impact, with healthcare costs being much larger in individuals with undiagnosed sleep apnea compared to individuals without sleep apnea, and higher costs in people with sleep apnea who are untreated compared to people with sleep apnea who are treated. So yes, there's a cost for treatment, but the cost of untreated sleep apnea outweighs that of the cost of treated sleep apnea. Fortunately, there are a variety of treatments for sleep apnea that are supported with clinical practice guidelines and practice parameters. So positive airway pressure, the green at the top, is the primary, the first line treatment for sleep apnea. It's probably the one with the greatest evidence base behind it. But there are other, PAP is not the only treatment. You have mandibular advancement devices. There's surgical interventions for people that qualify. There's more medically based, like positional therapies or weight control that have been found in some cases and in some people to improve the severity of the sleep apnea. But I'm really going to be talking about PAP therapy because that's the primary frontline treatment. But I should, before I get there, I should sort of share, probably many people have heard about newer devices that stimulate the hypoglossal nerve in order to activate the airway muscles to restore and widen the airway to restore breathing. So these are newer, these are out there. It is FDA approved, but currently there isn't a clinical practice guideline for its use. So I'm going to be talking about PAP therapy. That's a lot of the literature is on PAP therapy, which is basically a device with a mask and a hose that connects it to a machine that delivers pressurized air into the nose or the nose and mouth as the individual is sleeping, and that pressurized air helps keep that airway open. The benefits of sleep apnea treatment, I would venture to say they're undisputed. There's a wealth of evidence out there that when we treat sleep apnea using positive airway pressure therapy, the first line treatment, that it results in reduction of AFib recurrences and progression. It results in improved blood pressure control. It results in improved glucose control and improved insulin resistance. It results in, for individuals that are having surgery, non-cardiac related surgery, if you have sleep apnea but you're treated for it, there are reductions in respiratory complications that occur during the surgery, and there's a reduction in unplanned ICU admissions following the surgery. It reduces the risk of stroke, and it can improve health-related quality of life. There is controversy about whether treating sleep apnea can reverse or improve the brain-related changes that occur in the gray and white matter. There is controversy over whether it can result in cognitive improvement. There are many studies, well-designed studies, that have shown that people that are treated with positive airway pressure, when you re-image them a year later, there's actually a reduction in the hyperintensities, the pathological findings found in the gray and white matter, and that you can see improvement in cognitive test scores. Other studies have found that there's no change. But one thing to keep in mind is there are sort of differences methodologically in the studies that are out there in terms of how long was the follow-up from the baseline, how severe was the sleep apnea, Was adherence measured? And if adherence was measured, how was it defined? How did the studies ensure that the people that were treated were adhering to the positive airway pressure therapy when they were looking at changes in brain pathology and cognition over time? So it's not sort of a sure thing yet with these types of outcomes. There's still some debate in the literature. I'm going to talk a little bit about now the intersection between sleep apnea and TBI because they occur frequently. This is veteran data from the Veterans Administrative Database. There are millions of patients in this database. And this particular analysis focused on individuals seen between 2001 and 2015 and found that the rate of OSA using ICD codes was higher in individuals with TBI than without TBI. Our own research group who study individuals with moderate or severe TBI, and we gave everyone in this multi-center study, we gave everyone level 1 PSG. Comparing our group of moderate to severe TBI to the general population, we found also much higher rates of sleep apnea, whether we define sleep apnea as an AHA of at least 5 or AHI of at least 15, denoting more moderate to severe sleep apnea. So someone might be asking, okay, so I have a patient with TBI, I have a patient with sleep apnea, I'll just give them PAP. Like, what's the big deal about the co-occurrence? Well, the rate of adherence in individuals with brain injury, the rate of adherence to the treatment to PAP therapy is quite poor. So our group published this study back in 2017, I think 2018, where we looked at individuals with brain injury who were diagnosed with sleep apnea and found that 23% just refused treatment outright. And of the people who agreed to the treatment initially, 57% were non-adherent when we followed up with them. Medicare data also support that individuals with TBI are at greater risk for PAP non-adherence, with TBI being an independent predictor. What can we do about it? So the standard of care, if you go to the clinical practice guideline, if you have an individual who has sleep apnea, the standard of care is provide education about the disease, about the treatment, the consequences of not being treated, etc. It works. The standard education works for the general population of people with sleep apnea. It improves use by about half an hour a night. It improves the number of nights per used by almost, sorry, I misspoke there. So education does have a small improvement to the amount of time that people are using their PAP. The alternative to education are behavioral interventions. These are usually based on motivational interviewing, cognitive behavioral therapy, evidence-based behavioral treatments that have been applied to a wide variety of mental and emotional disorders, but also applied to adherence behaviors. But behavioral interventions are more resource intensive, take more time, there's special expertise that is required, it's not as widely available. And the clinical practice guideline recommends behavioral interventions as an alternative, not as the standard of care, but as an alternative. And the meta-analysis finds that behavioral interventions like those based on MI and CBT also improve adherence and improve it a little bit more. But are these behavioral interventions that are designed for cognitively impaired people, for example, individuals with moderate to severe TBI, are these behavioral interventions appropriate? Will they work? So cognitive behavioral therapies sort of rest on the assumption that the individual that is participating in the therapy sort of has the cognitive ability to participate in the therapy and the motivation to participate in the therapy. When there's a brain injury or another condition that causes cognitive impairment, the ability of that cognitive behavioral therapy to work as intended, there can be some barriers because of attentional deficits, because of aphasia, because of memory impairments, because of executive dysfunction. Those can pose barriers to engaging in the cognitive behavioral therapy. There are also motivational factors that sometimes brain injury can disrupt certain circuits of the brain that result in some of the motivational qualities of someone. And in some cases, some people call it adynamia, some people call it abula. In really severe cases, you can get akinetic mutism. But there is also just neurofatigue and anosognosia that can also impact a person's ability to fully be able to engage and benefit from cognitive behavioral therapies. But when adaptations are built into the therapy, that can improve the ability to deliver the CBT as intended and to have some sort of therapeutic benefit. What do I mean by adaptations? Well, adaptations are going to be different for every brain injured patient that you see because the deficits that they are going to bring to the office are going to be different based on the location and severity of their brain injury and things like time since injury. But adaptations, just to give some examples, shorter sessions, more frequent sessions, repetition, these can sort of help compensate for deficits in attention and deficits in memory, using reminders. Usually in psychology and cognitive behavioral therapies, the therapist will often try to elicit problem-solving strategies from the individual, but someone with a moderate or severe brain injury may have difficulty with abstract reasoning, may have difficulty formulating problem-solving strategies on their own. The therapist might have to take a more active and direct role in that regard. And also the inclusion of care partners in the therapy. Care partners being a spouse, a sibling, a significant other, parent, things of that nature. It's pretty typical in TBI rehab to have family members be a part of the treatment. There's a group in New Zealand, Jenny Ponford's group, that have applied motivational interviewing and cognitive behavior therapy to treat individuals with TBI for a variety of different types of mental and emotional disorders like anxiety, depression. It's also been applied to treating fatigue, sexual problems, and have found that these therapies, CBT and motivational interviewing, with these adaptations are feasible and in RCTs have been shown to have a beneficial effect. So, but these studies are the intention is to treat anxiety disorders, depression disorders, things of that nature. Has motivational interviewing and cognitive behavioral therapy, has this been adapted and applied in order to increase adherence behaviors in individuals with traumatic brain injury and sleep apnea? Well, to date, no. Well, no with an asterisk. Our group recently developed a 4-module behavioral intervention adapted from motivational interviewing specifically for the purpose of improving treatment adherence to PAP therapy in individuals with traumatic brain injury co-diagnosed with sleep apnea. I'm not going to get into it in too much detail because of just time constraints, but just in a nutshell, the 4-module intervention was developed with the health belief model in mind. It was delivered over telehealth or in person. And what our group did over this pilot trial, we tested the feasibility of this intervention. We screened individuals for sleep apnea and TBI. We provided the 4-module intervention and assessed a variety of symptoms before and after the intervention. We recruited these individuals from the Tampa VA. Skip this, this is not really so much important for the purpose of this talk. We examined PAP use over the course of the 4-module intervention and found that we did see an uptick of use. The top figure refers to hours of PAP use per evening. The bottom figure refers to the number of nights per week. And we do see a slight increase in average amounts of PAP use. Of course, huge confidence intervals given our small sample size, as this was just a pilot study. I'm going to skip this. I don't think this is super important. For this, I want to show that our participants did report some improvement in things like fatigue, sleepiness, self-efficacy. None of this powered to find a statistical significance, but our measures of effect size in the last column, Cohen's d, you can see small to moderate effect sizes. And so what we did was we tested the feasibility of the study. Our next step is to measure the effectiveness and study the implementation of this 4-module motivational interviewing based treatment adherence behavioral intervention. This was our study team. If folks are interested in reading the details of the results of the feasibility study, I have the citation here on this slide, which I believe these slides will be made available to everyone. So I'm just going to circle back, and what I hope that I accomplished today was sort of raising sort of awareness and appreciation for the detrimental effects of sleep apnea and how it co-occurs with TBI. The fact that treatment adherence is quite poor, like it is for a lot of health conditions. But there is ways to intervene. And so if you have individuals that have had a brain injury, that have sleep apnea, that are not adhering to their PAP therapy device, to consider consulting a psychologist or a counselor with experience treating individuals with moderate to severe TBI to sort of work with them on how to improve their adherence. With that, I'm going to end the slideshow. I'll stop presenting.
Thank you, Mark. I appreciate it.
And open it up to questions.
Thank you. Just right on time, like always. Mark is just always punctual as anyone I've met. So that's you have to be a TBI researcher. Let's see. I'm going to look at the chat a second to see if we had any questions. Mac Anderson, did that get answered? Because I had to step away for calling a call. Mac Anderson had asked, with control for CPAP adherence, is there outcome data that shows that treatment improves traumatic brain injury?
Sure. So in the general sleep population, so not referring specifically to individuals with cognitive impairment due to brain injury or otherwise, but there is literature. There's a well-designed study by Canessa and Castronova that did control for adherence. They recruited individuals with sleep apnea. They imaged them with MRI and gave them cognitive tests. And they re-imaged and administered the cognitive tests at 3 months post-injury and then at a year post, not post-injury, 3 months after the baseline, and then 1 year after the baseline. And they tracked PAP adherence and divided the group into those that were adherent using the CMS guideline of at least 4 hours a night, at least 70% of the time, and those who were not. And what they found was it was only the group that was adherent that demonstrated the beneficial, the improvements on the imaging, as well as the improvements on the cognitive tests, but that improvement was most apparent at the year outcome. So they were adherent to their therapy, but for the year. When they looked at the 3-month outcome, the results were equivocal. They weren't really necessarily showing that beneficial effect at the 3-month time point. I have those studies that I can share, and let me make a note to myself if people would find that valuable.
Mac, does that answer your question? You mean
It's not clear, Mark, was that a normal population or a TBI population?
That was a general sleep apnea population. I have not seen any studies that have examined whether treating sleep apnea and controlling for adherence, whether that will actually improve the rehabilitation outcomes. At this point, it's a hypothesis that we're testing. And the next grant that I'm writing.
excellent?
I like the sounds of that.
Excellent, timely. For those who don't know, Dr. Anderson, Dr. William Mac Anderson, and Dr. Dan Schwartz, in both of them, we have Tampa Bay area's longest running sleep medicine physicians. And that doesn't mean they're old. That just means they're very smart and very wise. So we are blessed to have both of them here. Dr. Schwartz rejoined the USF system in 2011 and joined under Mac, who is still section chief at the VA. And the reason I bring that up is those two were instrumental in getting Risa Richardson involved in sleep medicine, which is really instrumental in a lot of the avalanche effects of getting Risa involved in sleep medicine, and with her neuropsychology background tying into traumatic brain injury. So we really like to thank Dr. Anderson and Dr. Schwartz for all their contributions to sleep medicine in here at USF for really a long time. Thanks, Matt. Any other questions? I think that covered the chat.
Not a question, but just a comment. I just have to say that I'm very, very fortunate to have been able to work with Dan Schwartz and Dr. Anderson.
Absolutely. I can state that as well. As a trainee as well. All right. With that, then I think we'll wrap it up, which is perfect. You know, we've always wanted to try to finish at about 5 till to get everybody back to their clinics and their stuff. So appreciate it, Mark, for that very, very exhilarating talk. And next week, we will shift gears to cardiology and welcome back a USF medical student graduate, David Winchester. David is at UF in the Department of in the Division of Cardiology there. And David will be joining us for grand rounds next week. So again, thank you, Mark, and everybody have a great day.
Have a good day, everyone. Bye-bye.